Welcome, everybody, and thank you for having us today. So I'm Mike Cuttica. I'm a pulmonary critical care doctor at Northwestern.
I'm Ruben Mylvaganam. I'm also a pulmonary critical care doctor working alongside with Mike in the pulmonary hypertension world.
Yeah, so we are both, our clinical interest is pulmonary vascular disease. So we thought to lead off today, they asked us to talk about pulmonary hypertension, one of the complications we see in patients with scleroderma. And we thought, since we're the first speakers of the day, instead of giving you a lecture where we talk at you for an hour, we would do this more in a conversational way between us kind of talking about disease state, and we definitely want you guys involved. So it's a fairly small, intimate room, so if you guys want to yell out questions or comments, or if you've got a mic that is going around in the crowd, we can talk about that.
I'll start with saying that Mike and I were giving a talk last Saturday in the rain, and there was less than a third of the crowd for that talk, so this is great. It feels a lot more welcoming.
Yeah, absolutely. Very good. All right, so we are going to give an overview of pulmonary hypertension, talk about this disease state that we have built our careers around. So we've got a couple learning objectives that we really want to make sure we cover in our conversation today. So we want to talk about, really just define this diagnosis of pulmonary hypertension. What is pulmonary hypertension? What isn't pulmonary hypertension? And when are we worried about it? We want to discuss the testing that we put you guys as the patients through to both make the diagnosis of pulmonary hypertension and kind of give some background as to why we do them. We're going to discuss anybody in this room that has pulmonary hypertension or comes to see me and Ruben or your pulmonary or cardiologist that manages pulmonary hypertension knows that we always make you do a 6-minute walk test, and people hate the 6-minute walk test. We want to cover a little bit why we do the 6-minute walk test, why it's important, and the other tests that we're doing to follow patients over time. And then one of the big things in pulmonary hypertension over the last couple of years has been sort of a rethinking about the way we think about risk in patients, and using all of the testing that we put together to develop a risk score that then we hopefully are doing, if you're our patients, or your doctors, if you have pulmonary hypertension, they're following you, are talking about your risk score and using this as a starting point to talk about therapeutic options for you and why we think about, or how we think about treating you. So we're going to talk about risk scores and how we do those. Anything else? Okay. Okay, go ahead.
Yeah, so I think to start today, as you all know, diagnosing scleroderma is hard to do. It sort of takes a high index of suspicion of that disease state to be able to diagnose that disease. And then specifically within the world of scleroderma, trying to think about pulmonary hypertension does take an even higher index of suspicion. So we're going to ask the question of what symptoms would lead a physician, someone, or even you all to think about pulmonary hypertension, and then you'll see sort of why that index of suspicion needs to be high in order to think about pulmonary hypertension. So I'll
go ahead.
Start with that. So as you can see here, this is the most commonly reported symptoms for pulmonary hypertension in general, whether it's scleroderma or not scleroderma-associated pulmonary hypertension. As you can see on this slide, the most commonly reported symptom is shortness of breath, with about 86% of patients reporting shortness of breath. And you can tell that shortness of breath is a pretty nondescript symptom for any disease state. It could be associated with pulmonary hypertension, like we're talking about today. It could be associated with interstitial lung disease, which is also associated with scleroderma, or other more benign causes like asthma or smoking-related lung disease and so forth. So high index of suspicion, with the most commonly reported symptom being very nondescript. Other symptoms that are a little bit more specific to pulmonary hypertension involve exertional fatigue. If the pulmonary hypertension has gotten a little bit more advanced, people can feel lightheaded, dizzy. Hopefully not, but some patients can pass out with that disease state, so that's a scary symptom to report. And then because of the impact of pulmonary hypertension on the heart, sometimes patients develop increased fluid retention, and that fluid can end up in their legs or in their belly. So those are often symptoms that people report when they have pulmonary hypertension.
You can imagine from looking at these things, right? As we go through and define pulmonary hypertension, we know pulmonary hypertension is one of the two major lung complications that we see in patients with scleroderma. pulmonary hypertension can develop in anybody, independent of scleroderma. There are other things that can cause this, but in scleroderma specifically, it's one of two major lung complications. Our partner, Dr. Bemis, is going to talk about interstitial lung disease later, but you can imagine both in scleroderma and outside of scleroderma, these, as Ruben said, very nondescript or nonspecific symptoms can lead to significant delays in the diagnosis of pulmonary hypertension. So we have a lot of registry data over the years, both European registry data. In the United States, there's a large registry of patients with pulmonary hypertension that has shown from the time a patient first comes in complaining of symptoms till the time we actually make the diagnosis of pulmonary hypertension, on average, is about 2.5 to 3 years to getting that. So significant delays can come in, and it's exactly what Ruben said. People come in and say, oh, I'm short of breath. And most of the time, most physicians, most normal physicians who don't take care of rare diseases or fairly uncommon diseases like this would say, oh, it's probably asthma, it's probably COPD, maybe you're overweight and out of shape, and it leads to these delays. So we need to be, as physicians in the medical community, we need to be thinking about this diagnosis more frequently to be identifying it earlier, and certainly in patients, high-risk patient populations like patients with scleroderma, where we know up to 9% of patients with scleroderma will develop pulmonary hypertension in the course of their disease. We need to be thinking about it and screening earlier.
And I think along those lines, that study also showed us, about 3 years for patients to have been diagnosed with pulmonary hypertension. I think the other important part of that study was when they get diagnosed, they're often diagnosed in a later stage of their disease state, which means they have symptoms on the screen of the lightheadedness and the fainting. So the medical community here has come up with a good screening algorithm to try and help us determine earlier on in the disease of scleroderma when someone might be at risk for pulmonary hypertension and when we should
Yes,
go
ma'am.
diagnosing it.
So I have a question. With the lightheadedness and the fainting, and sometimes kind of feeling like the racing of the heartbeat, if you put a heart monitor on for 7 days, right?
Mhm.
Is it going to reflect what's really going on with the patient with this disease?
That's a great question. So other symptoms, how specific?
repeat the
Yep.
question?
She said with the lightheadedness and dizziness, the question is if you were to put on a heart monitor and monitor the rapid heart rate, and that would you be able to identify essentially the pulmonary hypertension or tell you something about disease? Does that sum it up, Baby? So that's a great question, right? And I think, again, these are pretty nonspecific symptoms. Even palpitations, rapid heart rate, none of these are really specific to pulmonary hypertension. And we know in scleroderma there are other things that can happen that can make people feel lightheaded or dizzy or even pass out. So I think the theme of this slide to me is, as a scleroderma patient, if you are experiencing shortness of breath, even if it's mild shortness of breath, something that just doesn't feel right, you need to talk to your doctor about it, right? Because you need to make sure you're being screened for pulmonary hypertension, interstitial lung disease. If you're having the other symptoms, I'm lightheaded, I'm dizzy, we need to both screen for pulmonary hypertension and we need to look for the other causes. So heart rate monitor might pick up things that would suggest pulmonary hypertension, but it would certainly rule out other bad things like, do you have abnormal heart rhythms or things that are making you pass out, which ultimately might be more common causes of feeling lightheaded than developing pulmonary hypertension, but no less important.
Yeah, exactly. Yeah, a good way to rule out other causes, and if those come back negative, having a high index suspicion for maybe we should do the other screening tests that we'll talk about briefly here to think about pulmonary hypertension.
Go for it.
Yeah, along those same lines, and we mentioned this just on the other slide, but there are some symptoms that we think should not be ignored, and those symptoms are, as we mentioned, lightheadedness, specifically fainting or passing out. That's a very alarming symptom, and in someone who has scleroderma, that should not be ignored. That should be brought up with your physician so that the underlying cause of that specific symptom, that specific complaint is explored a lot further, specifically looking for a cardiac cause of that complaint. So excessive swelling of the legs and the abdomen are important. That, again, highlights the idea that there might be an impact on the heart, and then the heart is congested and not being able to move that blood forward. Like mentioned earlier, irregular heartbeats or specifically chest pain. And then this last symptom here is more signs of low oxygen levels. So can happen in pulmonary hypertension, can very much so happen in Dr. Bemis's talk coming up, interstitial lung disease associated with pulmonary hypertension. So symptoms that should not be ignored. These should be brought to a physician's attention to be able to be worked up further. for the underlying cause.
And you might look at these things and say, who is going to ignore fainting? Who's going to ignore my leg swelling, right? I mean, these are, when you're sitting in a room like this, listening to a talk, you're like, yeah, obviously I'm going to ask my doctor about this. But, you know, sometimes these can be slow onset. Sometimes, you know, especially patients that are dealing with chronic illness, there are many things going on. You might be like, oh, yeah, my legs are swelling. I guess that's just part of scleroderma. And you don't think about it. These are important things to think about and to talk to your doctor about, because they may just be part of scleroderma, but they may be a sign of something else. Yes, ma'am. There's like a plant in the audience here. That's perfect. Yeah, I think that's the question was, what about echocardiogram? So let's move on to the next time. We're going to address that question coming up, because I think that's really important, right? As we think about these symptoms and talking to your doctor, right, there are actually guidelines that have been put out that suggest how the physician should be addressing a patient with these complaints to look for these. So we're going to talk about what is actually pulmonary hypertension. You want to take this?
Sure.
Yeah.
So like mentioned earlier, pulmonary hypertension is just the catch-all phrase for having high pressures in the lungs, pulmonary meaning lungs, hypertension meaning high blood pressure. Scleroderma and scleroderma-associated pulmonary hypertension is one form of pulmonary hypertension, but there are many other forms of pulmonary hypertension out there. The most common form in the world is the left side of the heart having high pressure, and that causing high pressure in the lungs. There are other forms like interstitial lung disease or low oxygen-related pulmonary hypertension. There's a chronic blood clots in the lungs causing pulmonary hypertension. We give that disease state the name CTEPH, or chronic thromboembolic pulmonary hypertension. And then there's the slightly more involved and treatable but scary disease called the precapillary pulmonary hypertension, which is the abnormal remodeling of the lungs blood vessels that causes the high pressure. And what a lot of what Mike and I do in our clinical practice, it is not so much treating patients, it's trying to make sure that we have a good understanding what kind of pulmonary hypertension patients have, because based on that understanding, the treatments change significantly. There are drugs to treat some kinds, there are drugs that hurt the other kinds, there are surgeries to treat others. So it's an important distinction to make, and so we spend a lot of our mind power trying to figure out why someone has pulmonary hypertension.
I agree. And I'm going to reiterate what Ruben said, and then we'll get to that question in 1 second. I'm going to reiterate this because I think this is super important. Pulmonary hypertension is an umbrella term. It means that the pressure in the lung is elevated. Not all types of pulmonary hypertension are the same. When we talk about pulmonary hypertension, this is all about the way your heart and your lungs are interacting with each other. And it's really important to know this, because without fail, for the 20 years I've been doing this, me and Ruben are working together for years now, patients come in, they get a test, CT and echo, something, they say pulmonary hypertension. You go to the internet, you Google pulmonary hypertension, and you read terrible things about this disease. When you're reading about it, when you read these terrible things, you're really reading about what we call type 1 pulmonary hypertension, as Ruben said, or group 1, what we used to call precapillary pulmonary hypertension, or now pulmonary arterial hypertension. Even in that setting, most of the things you read on the internet are no longer true. There are so many good therapies to treat this disease now that the scary things you read are not really true anymore. But as we think about this, right, pH is an umbrella term, just meaning high pressure in the lung. What's really important for the patient is what type of pulmonary hypertension do you have? Which of these 5 categories that we think of is really driving the disease? Is it a vascular disease where the blood vessels themselves are diseased? That's group 1. Is it a heart problem primarily, where the heart's not pumping well or the valves are abnormal in the heart? That's type 2. Is it lung disease related, like Dr. Bemis? Is it a patient with a bunch of interstitial lung disease and low oxygen levels and the pressures are up because of the lungs are damaged, like Dr. Bemis is going to talk about? Or are your blood vessels full of blood clots, what we call type 4? So the diagnostic workup that we put you through when we think about all the testing is really designed first to say, is the pressure really high in the lung? What's it doing to you, and why is it elevated? Because which of these categories you kind of fit into, and nothing's ever black and white in medicine. There's always shades of gray, and you might have a little of this and a little bit of that. But what we think your primary cause of high pressure is, that informs prognosis for you, and that informs how we're going to approach treatment. And the treatment of one type of pulmonary hypertension can make another type worse. So you really need to understand what type you have. You had a question?
Yes, I wanted to ask, I'm concerned we have pulmonary arterial
Yeah.
But in any case, so how do the two differ?
Yeah, so pulmonary arterial hypertension, like Mike just mentioned, is that group 1 disease, the one on the far left of the screen here. So this is the disease that is classically associated with scleroderma, and it's the thickening, fibrosis, scarring of the blood vessels of the lungs that lead into the parts of the lungs that help us participate in gas exchange, the parts of the lungs that allow us to get oxygen, get rid of carbon dioxide. That's the disease state that, as Mike mentioned, that back in the early 90s, there were not very many or any drugs at all to treat that disease, and now since this year and soon to be in 2024, there's 14 to 15 FDA-approved therapies to treat that disease. So it is a disease state that has evolved. It is a disease state that we have a good fair amount of experience with and a good amount of medications that we can use to treat that disease in order to prevent progression, ameliorate your symptoms, make the symptoms of shortness of breath and dyspnea or shortness of breath on exertion better, and improve the function of the right side of the heart, which is ultimately the thing that we care the most about, is how much this pressure is impacting the right side of the heart.
So the other way to think about it visually, as we think about these different groups, is this picture up in the upper right. There's a diagram of the cardiopulmonary circuit, we call it. Right now we've taken the heart and we've split it into two sides. So on the left, the RA is your right atrium, the RV is your right, oh, sorry. I don't think there's the right ventricle. Then you can see that blue vessel going into the lung. That's your pulmonary artery that's carrying the blood into the lung. Those little webs are what we, the description or the picture of what we call the capillary bed, where you actually get the exchange of gases, the tiny, tiny little blood vessels. And then the pink to red are the pulmonary veins that drain the blood back to the left side of the heart. So as we think about type 1 pulmonary arterial hypertension, it's really a disease of those blue vessels, the blood going into the lung. That's type 1, or pulmonary arterial hypertension. Type 2, or pulmonary venous hypertension, the heart problem, is really a disease of the pink, the blood vessels on the other side of the capillary bed, and then the other forms fit in there. All right. And as Ruben pointed out, this is the connective tissue diseases like scleroderma are one of the risk factors for group 1. And this is another visual picture of type 1, or group 1 pulmonary arterial hypertension. To answer your question, what is this? What is actually happening? We can see these sort of cartoon pictures here. Up in the upper left, this is a normal blood vessel, nice big tube, big pipe carrying the blood into the lung, blood flowing easily. As the heart pumps, it flows easily into the lung through these blood vessels on the arrow there. Moving into progressive PAH in the middle, the blood vessels start to thicken. The cells are growing abnormally. The lumen, or the tube part of the blood vessel, starts to narrow down. As it narrows down, it's harder for blood to flow through. The resistance to blood flow goes up. So now the pump, the right side of the heart's trying to push the blood through these pipes. The pipes are getting narrower. The right side of the heart says, this is getting harder. I don't like this. And then finally, in the late stage of the disease, you can see the blood vessel very, very abnormal, very hard for blood to get through. You actually get these abnormal growth of blood vessels, that kind of tufts that come off of the cells, off of the blood vessels. So it's like blind pouches of tubes going in there, and the resistance to blood flow is very high. This is what we think, or what we know from pathology studies, is happening in patients who develop type 1 or pulmonary arterial hypertension, which again is the primary thing we worry about in scleroderma. But as you'll see, scleroderma patients can develop pulmonary hypertension of almost any kind that we see in that categorization. So here again, just breaking down these 5 groups, thinking about how we think group 1, the pulmonary vascular disease, group 2, heart disease. You can see it listed underneath this. SSC is the acronym we use for scleroderma. The other types of connective tissue diseases like lupus, mixed connective tissue disease, RA, all of these autoimmune diseases put you at risk for type 1 pulmonary hypertension. But we know scleroderma, lupus, it can affect your heart. You can develop pulmonary hypertension through heart involvement, or type 2 pulmonary hypertension. It can certainly affect your lungs, lead to fibrosis, other changes in the lung. You can get pulmonary hypertension related to lung disease. Not typically in scleroderma, but in things like lupus, we think about clotting risk, and maybe you can develop clots and chronic clots in the lung if you have lupus or antiphospholipid antibody syndrome. So, right, as a scleroderma patient, when you present with shortness of breath and fatigue and these nonspecific symptoms, when you get to us, a lung doctor, or if your institution, it's cardiology that does pH, whoever your doctor is that manages a pulmonary hypertension, we need to be thinking about which of these 4 groups is this patient fit into, because the treatments are very different. Anything else?
Yeah, and that highlights exactly what Mike was saying. So this is why the diagnostic certainty is sort of needed from us to be able to decide what group you fit into so that we can decide the next step, which is really important to patients, which is how can we treat you to make you feel better.
All right, so how do we define pulmonary hypertension? Now we're going to get to your answer about the echo and the catheterization that you mentioned, the right heart catheterization that you've been through. So pulmonary hypertension is, we say, defined hemodynamically, which is the medical term that means we define this by measuring the pressure in the lung. So this has a couple of really important implications for the patient to think about this. One, if we are saying you have pulmonary hypertension and we're treating you specifically for the pulmonary hypertension, you have to have a right heart catheterization. We define pulmonary hypertension when the average pressure in the blood vessel in your lung is above a certain cutoff. Traditionally, we've said 25 millimeters of mercury is the cutoff for that. There is no way to measure the mean or the average pressure in the lung from an echocardiogram. The only way to measure the pressure in the lung is to get a right heart catheterization and directly measure the pressure. Right?
Sorry, and then the sort of thing that I describe in that situation is when you go to a doctor's office and you put a blood pressure cuff on your arm, you're measuring what the blood pressure is in the large artery of your arm, which is what the left side of the heart is pumping into. It's the blood vessel tree that the left side of the heart's pumping into. So that blood pressure cuff is measuring the pressure that the left side of the heart has to pump against to be able to move blood forward. Unfortunately, there is no blood pressure cuff you put around your chest to measure the pressure in the lungs that the right side of the heart has to pump into. So still, as it stands, the only way to measure that pressure is invasively, which is that right heart catheterization procedure. The echo is a suggestion, but it is not a diagnosis of pulmonary hypertension.
Exactly. Now, recently, in the last couple of years, as we like to do in medicine, people get together and we recategorize things over and over again. So in 2018, there was a world symposium, or this is the new guidelines that came out that changed the definition of the mean pressure from 25 and lowered it to 20. Might say, well, that's a pretty minor thing, but it was based on science, right? And the reason this was lowered is since the initial definition came out, we have now 30, 40 years of data that shows us that a normal average pressure in the lung, in a healthy lung, is about 14 millimeters of mercury, and that's plus or minus about 3 for a standard deviation in the normal range. So 20 really represents 2 standard deviations above the normal mean, and that's why we now define it as 20. From a patient standpoint, I don't think this really has a huge implication for you, other than to again, highlight, if we're going to be talking about treating pulmonary hypertension directly, we need to measure the pressure in the lung and know what the pressure is, and therefore you need a right heart catheterization. So this also from the guidelines that came out where we redefined pulmonary hypertension. I put this up, or we put this up here. This is about early detection, right? As we were talking about, she was talking about before, wanting to improve early detection of scleroderma. Both in scleroderma and outside of scleroderma, we want to improve that 3-year delay. We want to improve that time to identifying pulmonary hypertension so we can intervene earlier. And this we wanted to just highlight. This is an algorithm that was put together primarily for like primary care docs and rheumatologists and people who are thinking about pulmonary hypertension to identify the disease and then think about referral. So we're going to say, basically, when you have these symptoms and you go to your doctor and say, hey, I'm short of breath and it's not getting better. It's not good and bad days. I'm pretty short of breath. I'm pretty limited, or I'm passing out or whatever. We basically want to think about lung problems that can cause it, heart problems that can cause it. And then that raises the clinical index of suspicion for pulmonary hypertension. We're going to finally answer your question about echo in a second. And then I highlight this box down here that says if you're seeing somebody who is a rheumatologist that specializes in scleroderma, or if you're seeing your primary care doc and we're really thinking about pulmonary hypertension, we highlight the importance of referral to a center that specializes in PH. This isn't self-serving because we work at a center that specializes in PH. It doesn't have to be Northwestern. It can be any center that you go to. But when we finally get into the talking about how to treat this disease, the medicines are really specialized. People in the room know this, you're living with it. They are extremely expensive, they're hard to get, they're hard to maintain, they're hard to deliver. So we really, like you have at Northwestern physicians that this is all we do, and a team of nurses and nurse practitioners, advanced practice providers is all we do to really be able to provide that level of making sure that all treatment options are available for all patients.
And speaking to that, you can see on the right of the screen the fast track referrals, so scary symptoms, lightheadedness, passing out, and if we think pulmonary arterial hypertension is associated with that symptom, the fast track referral gets you to a PH center so that we can delay or prevent that delay to diagnosis and treatment.
All right, so what are the testing? We are eventually going to get to the echo. It's coming up in another slide here, right? It was a good question, but we're lung doctors, right? So the first test we're going to think about are lung testing. Why is this important? So when we think about lung testing, we think about imaging of the lung and pulmonary function tests. So I'm sure Brad is going to talk more about pulmonary function testing as well, because good set of pulmonary function testing helps to screen both for interstitial lung disease as well as screening for pulmonary hypertension in patients with scleroderma. So when we do pulmonary function tests, we measure how well air is moving in and out of your lungs, what we call spirometry. We measure the volumes of air in your lung, how much air is in your lung when you breathe as deeply as you can, and how much is in there when you breathe all the way out. And then from our standpoint, the last test that we do during pulmonary function tests is something called the diffusing capacity of carbon monoxide, or the DLCO. This is sort of a marker of the health of the vasculature in the lung. It tells us about how well is the lung getting oxygen from the lungs and into the blood. And this is important because if your diffusing capacity is low and everything else is normal on that, or if your diffusing capacity is dropping and the flows and the volumes are normal, that isolated reduction in the diffusing capacity is a pretty strong marker of a risk of developing pulmonary arterial hypertension, specifically in patients with scleroderma. This has been studied and well documented that the diffusing capacity is a really good screening test for a scleroderma patient to tell us, is this someone that's at risk for developing this vascular disease, type 1 pulmonary arterial hypertension. It can also help us say, we don't really think it's pulmonary arterial hypertension because maybe the volumes are low or maybe the flows are low, and we say you need to see our partner, Dr. Bemis, because we're worried that you've got interstitial lung disease.
And we do spend a good amount of time going through these PFTs, these lung function testing, looking at the not just the absolute values, but the change in values over time. So seeing that the DL, or the diffusion capacity, is dropping disproportionately lower than the volumes are dropping, or specifically looking at a ratio that we look at, and the rheumatologist and the interstitial lung disease look at too, that can help us detect, that's actually the name of the algorithm that we use to look for PFT evidence of pulmonary arterial hypertension. There's two questions, I think.
Go for it. Yes.
Is it possible that a low diffusion score would be predictive of Raynaud's?
Oh, that's a great question. Is it possible that a low diffusing capacity is a marker of Raynaud's? We could probably talk about this for an hour in the minutia of pulmonary medicine. It's a really good, insightful question. My answer, sort of the generic answer, is going to be no, because the diffusing capacity really is very specific to the vasculature in the lungs and not the Raynaud's that you get in the fingers and all that. Now, the changes that you get in the fingers with Raynaud's, where the vessels clamp down and your fingers turn purple and white and get painful and everything, there is a thought that the same sort of problem is going on in the vessels in the lungs that then leads to pulmonary hypertension. So maybe the diffusing capacity is telling us that some of those vascular changes of Raynaud's in the lung or something like that is going on, but that is a really good academic question that we spend a lot of time talking about, but don't have like a specific, way of testing for that.
I think what's important to know about that question is this test, that diffusion capacity, is not measured by putting a pulse oximeter on your finger. That diffusion capacity is measured by sitting in that glass box, breathing in carbon monoxide, and then measuring how much you're exhaling over serial breath. So it's not the pulse oximeter test.
Yes, ma'am.
Yeah, and is the diffusion capacity related to the issue of iron absorption?
Oh, that's another great question.
We do correct. You can.
It's tiny.
It's tiny on the screen. We do correct for the patient's overall you mentioned iron, but overall blood counts, or their hemoglobin level. So in patients who have lower blood counts, lower hemoglobin, that diffusion capacity will be lower, but then we auto-correct it. If we have your blood count on file, we'll correct it to what it should be based on your hemoglobin. So,
And also, I mean, not just the hemoglobin, but there are other iron tests, reticulated, something like that,
Mhm.
that sometimes are abnormal while the hemoglobin is normal.
correct,
Yep.
yeah.
And then on the right, we see a CT scan, right? So imaging of the lung is also important, both, as a screening test and helping to define what's going on. So we will look at CT scan sometimes to try and say, do you have interstitial lung disease? Do we see vascular changes in the lung where the blood vessels look big? Or if we give you a contrast agent, can we say, are there clots in the lung? The one thing I'll say is, obviously we don't want to put you through CT scans over and over and over again. That's cumulative radiation exposure. The dye, if we have to use it, can be rough on your kidneys. So oftentimes the pulmonary function will maybe sometimes do like a CT and a pulmonary function test to kind of establish a baseline, but really it's the serial pulmonary function testing over time that's a better screening test for interstitial lung disease and pulmonary vascular disease. Yes, ma'am.
So if your hemoglobin is above 12, is there a sort of a median diffusion capacity score? And you might have said what it was.
Yeah, so if you're anemic, so there, again, a question about the hemoglobin level and anemia. So if you're anemic, it will drop your diffusing capacity. It's one of the things that affects the diffusing capacity of carbon monoxide. We can correct through a formula for the degree of anemia to say the diffusing capacity is 20% of predicted, but when we correct it for the degree of anemia a patient has, it's actually 40%. Then we know it's not a vascular problem, it's the hemoglobin level that was causing it to go low. So that's how we correct the diffusing capacity for anemia. I know if you're asking, there is a formula we use for screening for pH. It's the forced vital capacity, or the FVC to DLCO ratio. So we take the forced vital capacity, that take a deep breath in, now blow, 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 blow all the way out. That a total amount you blow out, which is part of the spirometry. So that FVC divided by the diffusing capacity. If that number is elevated, then that's suggestive of pulmonary vascular disease. That's just basically a mathematical way of saying this person has an isolated reduction in the diffusing capacity. The diffusing capacity is low, but the forced vital capacity is normal. Yes, ma'am.
Is the diffusing capacity test just a standard part of a PFT?
Standard part of a full pulmonary function test. It's usually the last thing you do, where you breathe in, hold your breath for 10 seconds, and then breathe out. Finally, the answer to your question of the echocardiogram. Right? So the echocardiogram, we're lung doctors, but the echocardiogram is really the key screening test for pulmonary hypertension. You can't make the diagnosis, right? There's a number that we get on the echocardiogram, the estimated pulmonary artery systolic pressure, which is the top number of the blood pressure. It's not the mean pressure that we use to define the disease. But there is a wealth of information beyond that number that is much, much more important than just focusing on that number.
And this test is like the baby ultrasound that you guys have seen on TV, except instead of putting it down here in your abdomen, they're up here at your chest. So there's, depending on how we order the test, there's usually no IVs placed, but if we're looking for something, we'll ask for an IV because they give you contrast through the IV during this ultrasound. The contrast is not something that impacts the kidneys. And then they're taking a lot of images, so they're spending a good amount of time on your chest with that cold, hopefully warm ultrasound gel, capturing the images, and then we're looking at the images on the back end to try and say, do we think pulmonary hypertension is here? Because if there is truly meaningful pulmonary hypertension, it impacts the way the right side of the heart both looks and functions on the ultrasound. So we do spend a lot of time looking at these images.
So if you are a well-versed patient who is being screened for pulmonary hypertension and you get an echo and you go to talk to your doctor about the result of the echo, the question you want to ask is, what does the structure and the function of the right side of my heart look like? It's not what's the pressure estimate on the echo. That's a number we get that's important. I don't want to completely discount it, but that number that we get on the echo estimates the pressure. It can grossly overestimate, it can grossly underestimate. It tracks with what the actual pressure is, but we're estimating it. So to know really what is the value of the echo is to look like on this, you're seeing these two images. On the left is a normal echocardiogram. This is what we call a apical 4-chamber view of the heart, so we can see all 4 chambers, the 2 ventricles and the 2 atria. And then on the right is the echo of a patient with severe pulmonary hypertension. So if we look at this, the normal right ventricle on the left there, the RV, the RA, that's the right ventricle, the right atrium. The LV, the LA is the left ventricle and the left atrium. What we want to see on this is the right side of the heart nice and small? Can you pick up the right ventricle and put it inside the left ventricle? The right ventricle is a small, weak muscle. All it's supposed to do is push the blood into your lungs. As Ruben said, the left ventricle is the big, strong workhorse. It's got to pump the blood up to the top of your head, out to your fingers and your toes, generate this high pressure in your arms to get the blood to flow throughout the body. The right ventricle is just pushing the blood in the lung. So normally, small, weak muscle. You should be able to put the right ventricle inside the right atrium, or inside the left ventricle. On the right, we see the echo of an apical 4-chamber view of a patient that has pulmonary arterial hypertension. The right ventricle is enormous. It's probably bigger than the left ventricle. The right atrium is gigantic. You can't even see the left atrium anymore because the right atrium is so big, it's pushing over or squishing the left atrium there. So these structural changes of the right side of the heart are much more important to look at this and say, wow, the goal of all of our therapies is to get your echo to look like the one on the left. We want to normalize the size and the function of the right side of the heart. It's counterintuitive, but it's not really about lowering the pressure in your lung. It's about improving the size and the function of the right side of the heart. It doesn't really matter how high the pressure is. Once we know it's elevated and we make that diagnosis, ultimately it doesn't really matter how high the pressure is. What matters is, can we decrease the resistance to blood flow through the lung in a way that we take the stress off the heart and we get the right side of the heart to shrink back down to normal size, normal function. That's what's going to lead to much better long-term prognosis for a patient with PAH than saying, oh, the pressure's come down over time.
Questions that we sometimes get in this situation is, how often are you doing heart ultrasounds or echocardiograms? And then if you've been diagnosed with pulmonary hypertension, how often are you getting repeat heart ultrasounds? So I think it's someone in who you're not too clinically concerned for pulmonary hypertension. I would imagine that the screening echocardiograms are done maybe once yearly. Could be as frequently as every 6 months, but probably once yearly. If you've been diagnosed with pulmonary hypertension, you're seeing Mike and I or our colleagues out in other centers, and you're being started on medical therapy for pulmonary hypertension, we'll tend to repeat the heart ultrasound every 3 to 6 months, or sooner clinically if there's a change in your symptoms and something's not going the way that we think they are going. So we do these pretty frequently if you're in our world being treated for pulmonary hypertension.
Yes, ma'am.
What about the right heart catheterization?
I love it. You're a plant. That's great. So here is the right heart catheterization, right? So, and we've said, super important for making the diagnosis, usually potentially very useful down, like repeating it at some point in the career, in the course of the disease to help us make decisions around treatment. But this is, again, a picture of your heart. We see the right atrium, the right ventricle. A right heart catheterization, typically we place a large IV in the vein in the neck. Some people like to go through the leg. Sometimes we'll go through the arm. But the easiest thing for the patient, and technically, is usually to go in the right side of the neck with a large IV. And then this yellow dotted line is the representation of the catheter that then threads through that IV down through the right side of the heart, through the right atrium, through the right ventricle, makes the turn, goes up into your pulmonary artery, and then goes out into the lung. And this, you see these little graphs here are the pressure waveforms. This is what we look at, saying, well, when the catheter is in the right atrium, this is what the pressure waveform looks like. When it goes across your tricuspid valve into the right ventricle, it changes to the one on the left on the bottom. That's what the pressure tracing. This is how we know where the catheter is. And then we get it out into the lung, and we measure the pulmonary artery pressure, the blood pressure in the lung, systolic, top number, diastolic, and then the mean, which is important. And then on the end of that catheter that we've put into you as the patient, there's a little balloon that we inflate, and then we push that catheter as far out into the lung as we can until that balloon wedges into the blood vessel deep in the lung. And that allows us to measure the number called your wedge pressure, or your pulmonary capillary wedge pressure, which is essentially a measurement of what's the pressure in the left side of the heart. And through all of those numbers, the blood pressure in the right atrium, the blood pressure in the pulmonary artery, the wedge pressure, the pressure in the left side of the heart, that's how we define, is this type 1 pulmonary hypertension? Is this type 2 pulmonary hypertension? what exactly is the profile or the pressure picture in the lung. And the echo and the cath give us basically like two halves of the picture. The echocardiogram is the structure and the function of the right side of the heart. The cath is the pressures and the flows and the resistance and all of that. So at the time of diagnosis, super important to have both of these, echo and catheterization. Serially, as Ruben said, echocardiograms are generally good enough to tell us what's going on with the patient. If something weird is happening, you're not responding to the drugs the way we think you should, you're declining, we're not really sure we understand why patients are getting worse or something's happening, then we talk about repeating the right heart catheterization. That's our practice.
Yeah.
There are definitely practices out there. Your doctors may be in the practice that says, well, I do a right heart cath every year in a patient that I'm treating for PAH. That's not the wrong way to do it. This is a clinical practice type of thing, how people like to practice. We tend to repeat the cath only when there's something weird going on to help us understand the picture.
Saw some of the faces in the audience. This, other than the pain of the local lidocaine and the numbing medication, you do not feel anything on the inside. I'm not minimizing an invasive procedure. I'm just saying that it is a very well tolerated procedure. You do go home the same day after a procedure like this.
And from beginning to end, it should take about 25 minutes.
So that can that determine the difference between arterial and, yeah.
This is the key test that determines, do you have type 1 pulmonary arterial hypertension picture, or do you have type 2 pulmonary venous hypertension? And that really, I mean, we could, again, an hour lecture on the hemodynamics and talking about this, but that wedge pressure that I talked about, the pressure in the left side of the heart, that is a hugely important fork in the road in making the diagnosis for a patient with PH. If the wedge pressure is elevated, it makes us think this is a heart problem. We got to figure out what's going on with the heart. If the wedge pressure is low, this is a vascular problem like pulmonary arterial hypertension. We got to figure out what's going on with the blood vessels. So knowing that, getting all of the data from a right heart catheterization is very important.
And then the 6-minute walk test, which was mentioned earlier. So why do we do this, and why do we make you do it mostly every time that you come into the clinic? So it's a simple, inexpensive, reliable measure of your aerobic activity. It's not a perfect test. It's definitely an imperfect test, but it is a test that has been shown to correlate well with prognosis and with response to therapy. So we repeat this at intervals when we first meet you, before we sort of started patients on pH-directed therapy, and then at intervals afterwards in follow-up, usually 3 to 6 months at a time. We compare your walk distance initially to your walk distance after you started therapy, hopefully demonstrating that as you're starting on medications for this disease state, that you're able to walk further in that 6-minute time period after you started medications. The goal of medical therapy is to try and get your functional ability better. So you're going to be showing to us that you're walking further in those 6 minutes. During the test, we measure your heart rate, your oxygen level, your blood pressure, and we ask you to rate your subjective sense of breathlessness. And then I mentioned this at the end. So the distance at the baseline, and specifically the distance at the follow-up, not so much the change, but the distance at the follow-up, it's been associated with better long-term prognosis. We do this often. We do it because we know it has an impact on prognosis. And then Michael mentioned soon how this impacts our discussions around risk scores as well, because all the risk scores use this as part of one of their calculations.
Great. Super important. Annoying test. Everybody hates it. You got to walk up and down the hallway. We worry about it's crowded in the hallway sometimes, which we try and minimize. Sometimes you're like, oh, my legs are hurting today. That's going to affect how far I can walk. It's not really my breathing. It's my knee hurts or something. We know that there are limitations of this test, but when we look all over and over again, this test is one of the best tests to correlate with long-term prognosis in a patient with PAH, and serial measurement tells us about how you're responding to therapy. So, yes, sir.
What about smartwatches and data from that versus the 6-minute test? What's the kind of future of
Great question.
going?
What about smartwatches and all of our wearable devices and things? A couple of years, right before COVID, I participated in an advisory board where there were a whole bunch of physicians from all over the country talking about how do we actually use these things in our clinical practice, right? Because I'll have patients come in, we'll both have patients come in sometimes with reams of paper that they've printed up of like, well, this is what my heart rate is, and this is which is great, and it's important to monitor those things. How to actually use those in clinical practice is really hard. They actually tried to develop an app, a 6-minute walk test app, that patients could do the 6-minute walk test at home and measure that. I think that's probably important or useful for a patient to say, well, I'm doing this sort of lap and doing, and I can track over time how I'm feeling. So whether it's tracking heart rate or how much you're doing, I think that's good for a patient to be able to say, my trends are good. Just like everybody uses it. Like if I exercise a lot, I'm going to use my trends of my watch to tell me how I'm doing. Using them in clinical practice to make clinical decisions is much trickier, right? Because like the problem with the 6-minute walk app is we don't know, like where are you walking, right? Are you just walking a couple of feet up and down, or you walk in a couple of blocks? Whereas a 6-minute walk test in the clinic, there's a defined protocol developed by the American Thoracic Society and tested with normative values that we can say, you walk 100, it's a 100-meter course that you walk up and down, and there's supposed to be a script that people read to the patients about what exactly they do to try and standardize it. So I think those things are important, and you should be monitoring them if they're helpful to you to monitor your health and say, hey, I'm doing well, I'm not doing well, and then open up a discussion with your doctor. Then yeah, that's the realm of it right now. Maybe in a couple of years, we'll have the ability to collate that data and say, hey, you know what I want from your watch? I want to know what's your resting heart rate when you sleep at night, because that correlates with something important medically that's going to help us make decisions. Yes, ma'am.
I just wanted to ask, in the 6-minute walk, should one need oxygen, whether it's
Oh, that's a great question.
3 liters, the heart rate goes up? Is that a good indication that the changes are taking place with the lungs, with the heart?
Yeah, that's a great question. So I'll take it in two ways. So if you needed oxygen to walk at baseline before the start of the 6-minute walk test, Dr. Bemis decided that your lung disease is at the point where you need oxygen, and so we put you on oxygen. We ask you to do the walk on your baseline level of oxygen that you need with exertion. To mimic how you're doing this at home for those 6 minutes to make sure that we understand what your functional capacity is like. If you did not need oxygen, you're seeing us in the first time sort of trying to evaluate for pulmonary hypertension, and we're finding out that you do need oxygen on exertion. It certainly does clue us into the idea that something new and something is going on. And whether that's pulmonary hypertension or worsening of the lung disease or interstitial lung disease is an important thing for us to try and help you as the patient figure out. But it is something we pay very close attention to, because that is important to try and figure out what the underlying cause of that worsening vital sign measurement is.
A 6-minute walk test is different than an oxygen titration study. At its core, the 6-minute walk test should be done the same way every time someone comes in. I want you to walk at your fastest pace that you can do. You can stop as many times as you want, but you want to walk 6 minutes to get as far as you can. No one should be walking with you. Nobody should be monitoring your oxygen while you're walking. Nothing that interferes in your ability to walk the distance, because what we want to know is how far can you walk in 6 minutes? What's the oxygen at the beginning and the end? What's the heart rate at the beginning and the end? So this is a completely different test in theory than when we're titrating to say, do you need to wear oxygen, or are we worried how low your oxygen levels are going? When we do a 6-minute walk test, it's a functional test. How far can you go in 6 minutes? So that's how that walk test should be performed. If we're worried, like, oh, she's got lung disease, or this patient has lung disease, I'm worried they need oxygen, then we should be doing an oxygen titration study where someone's walking with you and measuring it and titrating the oxygen up and down. And as Ruben said, a 6-minute walk test, from a patient standpoint, if you wear 2 liters at home, you should do 2 liters when you walk. Then the next time you come back, you should do the walk test on 2 liters. It should be the same way every time. Unless something big changes and you've gotten so good that you don't have to wear oxygen anymore, then we can change what your baseline is. But the walk test should be done the same way every time. All right, last couple slides, because we're going to run out of time in a minute. How do we think about risk in pulmonary hypertension? So I'll start with this. So like I said, in the last couple of years, there's been a lot of changes in the way we think about all of the testing that we do, right? There's been a real push to try and standardize the way we use the tests and come up with how we think the patient is doing, what the prognosis is. So this highlights 3 different risk calculators that we use. So I mentioned before, in the United States, there's a big registry called the REVEAL registry. One of the major publications that came out of this was the REVEAL risk score, which at its first iteration was using things like what type of pulmonary hypertension does this person have, or what subgroup of type 1 pulmonary hypertension does this patient have? How old is the patient? What's the kidney function? What's the BNP, or the B-type natriuretic peptide lab? How far does the patient walk on a 6-minute walk test? Some echo parameters. All of these things that we use sort of traditionally as the gestalt of the physician looking at this and saying, oh, I think this patient's doing well. We take all of these things and they put together a risk score that allows us to calculate a patient as low, intermediate, or high risk. And in its first iteration, this basically had prognostic value for a patient. You could say, this patient is high risk, and therefore the risk of this patient dying in 1 year is this, or this patient is low risk, and the risk of them dying in 1 year is this. And then we use that to talk about treatment. How this has evolved in a very kind of, from a nerdy doctor standpoint, very exciting kind of way, is that we've seen now, if we follow the REVEAL risk score serially, or on the right, this is the European risk score, they all basically are the same thing. They just sort of tweak the numbers a little bit differently, but come up with a risk scoring system. What's really exciting about this is that we've seen, I think I'll say two things. One, someone did a small study that looked at the gestalt of a physician looking at these things and saying, oh yeah, I think this person's high risk, low risk, or intermediate risk, and then the actual calculated risk score. And it showed that doctors were really bad at the gestalt of saying this patient is what the risk for a patient is. The risk score really helps to objectify the numbers and give us something to think about, right? So we don't want to discount the clinical acumen of a doctor and saying, I think we need to do this or that, but I think this risk score should help inform the physician about maybe this person's a little bit higher risk than I realized just looking at them, right? Because sometimes you guys walk into clinic, and we say, oh, this person, they're looking pretty good. They say they're feeling pretty good, but that BNP score is a little bit higher than it was before, or you don't walk quite as far as you did before, and we kind of discount that to, well, maybe the patient's having a bad day or not. But what this scoring system does is it should reset the physician's way of thinking about the patient, or at least informing the conversation with the patient about how we're going to think about treating. So that's one thing that I think is important about this, is that sometimes we're not great about recognizing the risk of a patient when we're just looking at you in clinic. And this scoring system should help the physician reset how we think about you. And the second thing that I think is super important about this was when we look at these scores serially in a patient, there's now data that suggests if we take a patient that's high risk and we treat them, and at follow-up we've moved them into a lower risk category, that person has a much better long-term survival. If we say that at baseline I should go to the next slide, right? So if you look at this bottom thing with the big arrow on it is what we call a Kaplan-Meier survival curve. So this is looking at large groups of patients and looking at how many years do patients survive? What's the survival like at 5 years or 10 years? And you can see each of the different colored lines in there represent high risk, low risk, intermediate risk. And what this graph shows us is that people that are at low risk have really good long-term survival, right? If we have someone at baseline that is a low risk, their 10-year survival is, like 80%, something like that, the likelihood of being alive in 10 years. If you take a patient that's intermediate risk, where the 10-year survival drops down to like 50 or 60%, if you can move them into the low-risk group, their survival is like you were at low risk at the beginning. So we can use this the REVEAL risk score as a marker of, are we actually impacting the long-term survival of a patient, which is super important, because if as you guys know, these drugs are, as we said at the beginning, expensive, hard to get, they're really hard to deliver. We're talking about sometimes giving you infusion medicines where you carry around a pump, or you have to inhale something 4 times a day that takes 10 minutes to do it, right? These can be really hard. But if we say to you, when we look at your REVEAL risk score, you're still at intermediate risk, and I'm worried about you because you're intermediate risk, and I think you need to go on a pump because I want to get you into the low risk group because I know that's going to impact your long-term survival. If we can get you into the low risk group, that is a pretty powerful tool for us as your doctors.
Yeah, said it well. We look at this a lot, and we use this in our conversations to talk about therapy, because you can see pretty nicely where that large arrow is, that there is a good separation if we can move you from a high, intermediate high to an intermediate low or low risk group. And that's what we use our medical therapy to try and get patients to.
So if you're a patient that has type 1 pulmonary arterial hypertension, every time you go into your doctor who treats your pulmonary hypertension, you should be asking, what is my risk score? Whether it's REVEAL risk score or the European risk score, it doesn't matter what risk score it is. We want to know what is your risk score. And they may not be able to tell you that at the time you're there, because we need, like, the WHO functional class is us asking you, like, are you short of breath at rest? Do you get short of breath when you're showering? Can you walk a block? Can you go up a flight of steps? That gives us your New York Heart Association functional class, how we grade people. You have to do the 6-minute walk test. The distance of the 6-minute walk test is very predictive of outcomes and risk. And then you need the blood work. So if you haven't had the BNP lab or the NT-proBNP lab when you're in the clinic with the doc, they may not know what your risk score is, but you should say, should I go to the lab and get this done today? Because I want to know what my REVEAL risk score is, or my risk score is because I want to know, is my therapy working for me? Right on the money, 10:15. Yes, ma'am.
So I have a question for you in regards to that being out of breath, going up the stairs. A lot of times she gets dismissed because of all the meds that she's on, and it becomes like, oh, well, it's a medicine thing. So we have a really hard time as a family trying to balance out, what that is.
Yep, that's a good point, right? There are, I don't know the best way to answer that for you as specifically as the family, right? Because you're right. When you come in and say, oh, I'm winded when I'm walking up the steps, or I'm winded when I'm walking down the street, there are a lot of things that can cause that. I can't think of a really easy way to attribute it to your medicines, unless your medicines are making your blood pressure too low or something like that. But I think being persistent with the team, saying, look, I don't think this is not normal for her, right? Because normal is no longer normal. Normal is normal for you, right? You're sick and you've got a disease where you're limited. But if you keep persistently saying, this is not normal for me, I am not where I want to be, then the onus is on us as your doctors to say, well, maybe you need an echo, because maybe we're not actually getting you where we've normalized the right side of the heart. Or maybe we need to really look at that REVEAL risk score and say, are you really accomplishing what you need? And ultimately, your lung doc or your cardiologist might say, your pH looks really good. The right side of the heart's good, your REVEAL risk score is low, and therefore we need to look outside of this as the cause for why you're feeling crappy. And maybe it is your meds and we got to change something else. But it's complicated because you've got to look through and make sure we're looking at the whole picture. You want to make sure we're thinking about pH and all of that first, but then make sure there aren't other things as well. Yes, sir.
Do you guys have relevant statistics for the rate of occurrence for pulmonary hypertension group 1 in patients with systemic sclerosis?
Yep. So it's about 9% of patients with scleroderma will develop PAH in the course of their disease. The number is higher when you start thinking about interstitial lung disease associated PAH, or is there heart involvement? That's group 3, exactly. And then group 2 is if there's heart involvement. So, but it's specifically if we're like, what is the risk of developing PAH, where we're talking about risk scores in the right side of the heart, primarily about 9% of scleroderma patients. Last question. Yep.
Sorry to repeat the echo again, but what if you've hit several and they seem to have kind of a hard time determining the right side pressure? Like they're just not able to get a good number, or they don't feel like they can see it clearly. Is that sometimes, because I've had injections where they do the TR jet thing or something.
Yeah, that's a very good question. The right side of the heart's a very hard side of the heart to... Yeah, sorry, I'll repeat the question. The question was, what if you've had serial echocardiograms done and they cannot estimate the right-sided pressures or the TR jet velocity, and they have to use things like Definity or contrast agents to try and see that better? What do we do in that situation, I think is your question. That's a great question, and I'll say that the right side of the heart is notoriously very hard to see and notoriously very hard to accurately measure on an echocardiogram, so there are inherent like Mike was saying, black and white, it's always shades of gray in medicine. There is limitations with the echocardiogram. If your treating physician feels that there is a strong suspicion that pulmonary hypertension might be at play, or if they want to take that off the table in terms of a reason why someone's feeling short of breath or breathless, and we're not getting enough good information from an echocardiogram, in someone who has scleroderma, it is not unreasonable to think about doing a diagnostic right heart catheterization at that point, even in light of having a reportedly normal right side of the heart on the echocardiogram, to say that this is not pulmonary hypertension, or to say, actually, this is pulmonary hypertension. We need to think about this a little bit differently. So we use it as a package with all the other testing, the lung function testing, the CT scans, and specifically the trends in how you're functioning. Remember, pulmonary hypertension is a progressive disease, so we expect things to get worse if we're not treating you.
All right, thanks for the Scleroderma Foundation again for having us, and all you guys, it's been a great discussion. I really enjoyed it. Thank you.